Welcome! This video covers 5 high-yield MCQs related to obstetrics and gynecology that are frequently tested in various medical examinations. Have a glance on these topics. You can locate the timeline of each MCQ in the description.
Multiple choice question number 1.
A 32-year-old woman, gravida 3 para 2, presents at 37 weeks gestation with severe sudden onset hypertension, BP 180/110 millimeters of mercury, headache, visual disturbances, and epigastric pain. Her labs show thrombocytopenia, elevated liver enzymes, AST 150 U per liter, and urine protein 3+. Fetal monitoring reveals late decelerations. She has no seizures. What is the most appropriate immediate management? A. Administer intravenous magnesium sulfate and prepare for urgent cesarean delivery. B. Initiate oral antihypertensives and plan induction of labor. C. Administer corticosteroids and observe for spontaneous labor. D. Perform emergency vaginal delivery with forceps or vacuum extraction. E. Delay delivery and treat conservatively for preeclampsia.
A is the answer. The management of severe preeclampsia centers on rapid stabilization of maternal condition and urgent delivery to prevent complications. Intravenous magnesium sulfate is critical to prevent progression to eclampsia by reducing the risk of seizures. Severe hypertension must be controlled promptly using appropriate antihypertensive agents, as uncontrolled blood pressure can lead to stroke and organ damage. Although corticosteroids accelerate fetal lung maturity, their use is primarily before 34 weeks. At term, 37 weeks or later, immediate delivery is imperative to reduce maternal and fetal risks. Vaginal delivery may be contraindicated when there are signs of fetal compromise or maternal instability, making cesarean sections safer in such cases. Delaying delivery in severe preeclampsia increases risks like placental abruption, organ failure, and fetal demise. Therefore, multidisciplinary coordination involving obstetricians, anesthetists, and neonatologists is essential to optimize outcomes for both mother and baby, balancing the urgency of delivery against maternal and fetal health status.
Multiple choice question number 2.
A 26-year-old woman has secondary amenorrhea for 6 months, galactorrhea, and headaches. Serum prolactin is elevated. What is the next best investigation? A. Thyroid function tests. B. Pituitary MRI. C. Endometrial biopsy. D. Pelvic ultrasound. And E. Hysterosalpingography.
B is the answer. The best next investigation is a pituitary MRI. Elevated prolactin in this context usually suggests a prolactinoma, which is a pituitary tumor, which can cause these symptoms, including headache, due to tumor mass effect. While thyroid function tests are important to exclude hypothyroidism as a secondary cause of hyperprolactinemia, the presence of symptoms like headaches and galactorrhea with elevated prolactin strongly prioritize pituitary imaging. Endometrial biopsy, pelvic ultrasound, and hysterosalpingography are not first-line investigations in this scenario, since the primary problem is hormonal and central in origin, not structural uterine pathology.
Multiple choice question number 3.
A 31-year-old pregnant woman at 36 weeks presents with severe hypertension, proteinuria, and headache. Fundoscopy shows papilledema. What is the diagnosis? A. Gestational hypertension. B. Preeclampsia. C. Eclampsia. D. HELLP syndrome. E. Chronic hypertension.
The answer is B. The diagnosis for a 31-year-old pregnant woman at 36 weeks presenting with severe hypertension, proteinuria, headache, and papilledema is preeclampsia. It is characterized by new onset hypertension after 20 weeks plus proteinuria and/or signs of end organ damage, such as headaches and papilledema. Optic disc swelling due to increased intracranial pressure. Gestational hypertension A involves new hypertension after 20 weeks but without proteinuria or organ signs. Eclampsia C includes all features of preeclampsia plus seizures, which are not mentioned here. HELLP syndrome, D, is a severe form of preeclampsia with hemolysis, elevated liver enzymes, low platelets, which requires lab confirmation and distinct clinical features. Chronic hypertension, E, is hypertension predating pregnancy or diagnosed before 20 weeks gestation without proteinuria.
Multiple choice question number 4.
A 34-year-old pregnant woman at 32 weeks gestation presents with severe right upper quadrant pain, nausea, and hypertension. Labs show elevated liver enzymes and low platelets. What is the most likely diagnosis? A. HELLP syndrome. B. Acute fatty liver of pregnancy. C. Cholelithiasis. D. Pre-eclampsia. E. Viral hepatitis.
The answer is A. HELLP syndrome is a severe form of preeclampsia characterized by hemolysis, elevated liver enzymes, and low platelets. It commonly presents in the third trimester with symptoms like right upper quadrant or epigastric pain, nausea, hypertension, and laboratory findings of elevated AST or ALT and thrombocytopenia. Acute fatty liver of pregnancy can present similarly, but typically involves more severe liver dysfunction and encephalopathy. Cholelithiasis and viral hepatitis may cause right upper quadrant pain and elevated liver enzymes, but are less likely to present with hypertension and low platelets. Preeclampsia alone usually does not have such significant platelet drop or liver enzyme elevation without progression to HELLP.
Multiple choice question number 5.
A 28-year-old pregnant woman at 34 weeks gestation presents with painless vaginal bleeding. Ultrasound shows placenta covering internal cervical os. What is the management? A. Bed rest and cesarean section planned at term. B. Immediate induction of labor. C. Vaginal delivery now. D. Cervical cerclage. E. Expectant management without restrictions.
A is the answer. The management of a 28-year-old pregnant woman at 34 weeks gestation with painless vaginal bleeding and ultrasound showing placenta covering the internal cervical os, Placenta Previa, is to plan for cesarean section delivery, ideally at 36 to 37 weeks. Placenta previa involves the placenta covering the cervical os, making vaginal delivery unsafe due to risk of severe hemorrhage. Immediate induction or vaginal delivery is contraindicated because it risks life-threatening bleeding. Bed rest, reduced activity, and avoiding intercourse are usually advised. However, definitive management is planned cesarean delivery at or near term, 36 to 37 weeks, if bleeding is controlled and both mother and fetus are stable. Expectant management without restrictions is unsafe due to bleeding risks. Cervical cerclage is not indicated. Thus, the best approach is careful monitoring with planned cesarean section at term with preparation for possible emergency delivery if bleeding worsens.